common scale. Let's finish off this this chat here. I've said that on some levels it's going to be difficult for people to really give you a good number. We recognize that, right? We're asking them to distill a whole lot of information of an experience down to a single number. However, there are certainly some merits to doing so, and by no means am I saying stop collecting the numeric rating scale. I still think it's very important. So a couple of merits, right? As I mentioned, it's easy to administer and score. I can do it anytime. I can do it orally. It seems to work just as well as doing it on paper. It's a quick omnibus proxy. There we go. Look at me being sesquipedalian again. It's basically it's an overall sort of quick view of kind of high level what's happening from here. It's generally acceptable by patients. It has a lower error rate than the VAS. It can be universal, and what I mean by that is, as far as we know, it works equally well in any language. And it's applicable across clinical populations, so it's not specific to a population, which is great. However, we need to recognize a couple of limitations here. It gives you relatively little information for guiding your treatment experience or treatment decisions, right? So if someone says it's 6 out of 10, what's that mean? Really, what should I do with that? You know, it's a great thing. I'll write it down on my chart, but it doesn't really tell me what to do about it. Usually addresses only a single point in time. Now, we were just talking, Ian and I were just talking in the back around the time frame that you would normally ask this question around. And some of the scales that we're going to look at here shortly, you'll see will have different time frames built into them. Some will say over the past 48 hours, over the past week, at its best, at its worst, on average, right now. Again, as I mentioned, you can influence the response you get on these scales by virtue of the way you ask the question. Not only is the anchor going to change that, but the time frame over which you're asking them to consider is also going to change that. So if I ask the question something like, what's your pain sitting here right now in front of me? Here's an interesting little finding. A couple of years ago, a fellow by the name of Krebs published a paper that says they went and surveyed people sitting in a weight room at a physician's office. And they asked them, first of all, what you here for? And a number of people said, I was here for some pain-related problem. They asked the person to then give us a rating right now of your pain on a 0 to 10 scale. 21% of the people gave them a score of 0, sitting there right now. Okay? If we were to use this as a screening tool for identifying people who were actually here for a reason of pain, it's actually not that great, which is interesting, right? Because you think this is how we're rating pain. So we just recognize that asking what you're feeling right now, what I don't know, for example, is what you've done before you came to feel that way. You know, many people I know, as a physio, many people will say, well, my doctor told me to take my Tylenol 3s or my, you know, whatever my drug of choice is before I come because you're probably going to hurt me. So, which I always thought really doesn't do us any good, but nonetheless, they've already taken something. So it's entirely possible that right now they're actually fairly well under control, right? Again, that doesn't really give me a whole bunch of information around treatment decisions. Your anchors are often not consistent, especially across research. Go and look, you'll see, it's remarkable. Doesn't consider frequency, quality, or location, so we'll talk about those next. Usually requires some deeper exploration. So really that pain score should lead you into further questions. And arguably most importantly, I think, is that it should not be used to compare between patients. Interestingly, I was at a talk a couple of years ago, it was actually I think at IASP, and a group basically delivered this podium presentation for an hour saying that the pain scale can be used across patients. 0 to 10 is 0 to 10 no matter who you are. The only thing that's different is your genetic sensitivity to pain. So if they score differently to a specific standardized stimulus, it's because they're genetically more sensitive to pain. The only reason I bring that up, I don't really subscribe to that, to be perfectly honest. I'm not meaning to criticize research. I'm sure the research was fine, but it just hasn't worked for me clinically, let's put it that way. But the reason I bring that up is because there is actually even some debate out there around whether you can, in fact, apply this and compare between patients. So some people think you can. It hasn't worked for me, but maybe for some it can. We've already answered this question, so I'll leave it here for now. Meaningful change on a 0 to 10 numeric rating scale is about 2 points, and that is about the case. It ranges 1 to maybe 2.5 or so points. But if we're going to use this for evaluative purposes, we should know what a meaningful change is. I'm going to give you a caveat on this. You've probably heard this idea of like minimum clinically important difference or minimum detectable change, that sort of thing. It's a function of the reliability of the tool. As I mentioned earlier, I do a fair bit of analyses of different tools. And one of the approaches that I'll use commonly is called rash analysis. And what rash analysis does is basically says, how well does this ordinal level scale really work as a linear scale? Okay, put it in a nutshell. Anyway, the reason I tell you that is so I can tell you this. Every time that I've analyzed a scale, or that anyone else that I know of has analyzed a scale using this type of analysis, we have found that the responsiveness of a tool is not consistent across the entire breadth of the tool. Usually what will happen is at the extremes of the scale, a small change is meaningful. Whereas in the middle of the scale, a small change is probably not very meaningful. And if you think about this, this makes conceptual sense. Okay? Think about the difference between a 0, I have no pain, and a 1, which is crossing some kind of invisible but probably important threshold of going from nothing to something, right? So clearly, there's something important about that. On the other hand, think about your patient who, for the past 3 months, every time you've asked them, my pain's a 10, it's a 10, my pain's a 10 today, it's 10 out of 10, it's 10, it's 10. At its best, it's 10, it's 10, it's 10. Today it's 9. Now, one of you tell me that that's not important. Clearly that's important. So, at the extremes of this scale, probably a 1-point change is actually important. But generally in the midpoints, probably from 2 or 3 to 7 or 8, a 2-point change is considered to be important. Okay? Oh, here we go. Of the following pain rating scales, which is the most appropriate, cognitively intact working age adults? So it looks like we are heading in arguably the right direction. There are very rarely right or wrong answers to this sort of thing, but in this case, if you look at the balance of the evidence and the literature, the numeric rating scale works at least as well, if not better, than a lot of other, even more sort of complex multi-level scales. Fewer errors, more culturally applicable across cultures, which is one thing that, for example, Long Baker doesn't necessarily do. So really, I would say the numeric rating scale of any of them is probably the most appropriate. And the nice thing about there is also the easiest. So we might as well keep using it. So to summarize this module on the numeric rating scale, it's certainly the most common clinical evaluation tool, but it's not always used consistently. Changing the anchors, as well as changing the time frame over which you're asking somebody to think about their pain, is going to change the meaning of probably the response you get of that scale. It's useful for prognosis. It can be useful for evaluating change over time. It can be useful for discharge planning, not as useful for treatment decisions. Don't use it to compare between individuals. As I say, my 3 and your 3 are probably very different. Patients who score beyond 10 don't need to be doubted. But why don't you explore that experience a little bit further? For acute trauma, as I mentioned, a scale greater than 5 out of 10, so 6 out of 10 or higher, generally suggests a worse prognosis. Certainly the higher the worse. And for evaluating change, a difference of 2 points is usually meaningful. A 1-point difference may be meaningful at the end of the scales. Any questions on just the numeric rating scale that I haven't covered?
Sorry, I just have a thought. Because in clinics, we're often taught to choose grades of manual therapy based on pain scale.
Right.
So.
Good point. So the comment was that during training, during physio training, in manual therapy courses, they're often encouraged to choose really the magnitude of mobilization based on the patient's pain rating scale. And certainly we use that. I don't know if you've ever, do they still talk about irritability of pain in the condition, right? So intensity and duration. What's the third one? Vigor, right. Still up there, kids. Like 15 years, still up there. Right, so yeah, that's another good point. And I think that again speaks to why it's so important to understand the utility of this scale. That's a case where it is actually guiding your treatment decisions. Whether it should be or not is another story, but it is actually guiding your treatment decisions. You know, how vigorously are you going to go at these mobilizations? So you need to think about how you're going to get the appropriate answer from this scale. And as I said earlier, you can probably change the response you get by virtue of changing the way you ask that question, which could then change your treatment decisions, right? So yeah, it is important consideration. Any other questions on that?